Hi, morning guys. Sorry, afternoon guys. I hope you guys okay. Welcome back to the Food Comes Series of Mork. Today we're gonna do two stations as usual. First of all, I'm sure all of you know me by now. My name is Miet. I'm a cardiac surgery registrar, and I'm finishing my PhD at the Imperial College London as well. So today, as I said, we're gonna do two stations. First station will be 10 minutes, like in the real exam. So the first minute you're going to read the candidate instructions, and the station will be the same as well. So first minute you're going to read the candidate instructions, and then you've got 9 minutes left in the actual station. Out of that 9 minutes, you will have to do the station. There will be a 6 minute both. So let's say if you are doing a skill station like history or examination, then you have to use that 6 minutes to take the history or do the examination, and then I'll ask you the follow-up questions in the last 3 minutes. If this is a knowledge station, then you just crack on answering all the questions. Once we've done the station, I'll give a brief individual feedback to the person who has done the station, and then we'll move on to the next station. So to run the mock, I need two volunteers. I can see Pratia's already raised his hand. So I need one more volunteer. So as you can see, this is our website, mrcsbootcamp.com. We are migrating to a new portal. So it's a new we'll use both portals nowadays. So the knowledge part will still use the old portal, and the other skills part will use the new portal. So the knowledge part is still under migration at the moment. So hopefully we'll complete it before the end of the month. And then we've got Facebook page, and make sure you are in the Telegram groups and the WhatsApp groups where we send out the links here. Great. So Pradir will do the first station, and Ahmed will do the second station. So Pradir, can you hear me? Can you hear me, Pradir?
Yes.
All right, okay. So I'm going to mute all of you during the station. After the station, I will let you mute and then jump on in the discussions. Let me unmute you first. We'll move on. Great. So I'm going to set the timer, and here we go. How would you confirm the diagnosis?
I would like to take temporal artery biopsy for this case. This is mostly giant cell arteritis.
Mhm. So any other investigations that will point or confirm towards the
Uh,
trans
raised
ulcer?
ESR, raised
Mhm.
ESR. Uh, then I would take inflammatory markers, complete blood picture, CRP. Uh, also, the gold standard is temporal artery biopsy.
So temporal artery biopsy takes a bit of time. So anything else?
Uh, it's a clinical diagnosis, like it's a emergency, and because there is also already a transient loss of vision, I will start with IV methylprednisolone straight away.
I'm going to stop you there. So in terms of the investigations, not the management, would you like to do anything else?
Uh, no, yes.
Can you tell me the pathophysiology of the giant cell arteritis?
There is granulomatous inflammation of the artery, large artery, which causes uh, the there is which causes the constriction of the arteries. So there is, and it also affects the retinal artery, which causes the loss of vision, and also there is granulomatous inflammation in the tunica media and intima of the artery.
All right. And so anything else apart from the retinal artery that can cause the loss of vision?
Uh, the, the the ophthalmic artery also.
Ophthalmic artery as a whole or any other arteries?
Uh, the branch of ophthalmic artery,
So which branch is it?
uh, anterior retinal, central retinal artery, CR.
Anything else? All right.
Uh,
So how would you manage the patient?
I will start with the high dose methylprednisolone. Also, um, I'll do fundoscopic examination to confirm the pathology, and also uh,
So can you confirm the pathology using fundoscope?
uh, there will be there will be the fundus of the central retina will be ischemic. So uh, the emergent treatment is high dose methylprednisolone.
So overall giant cell arteritis, how would you manage?
Uh, we can do uh, just diagnosis methylprednisolone.
Is it always methylprednisolone?
We can give hydrocortisone also, or plasmapheresis would be
What is the aim of doing plasmapheresis?
uh, to remove the autoantibodies or inflammation, inflammatory inflammation, the cytokine storm. Uh, we can give IL-6 antagonist like uh, adalimumab, or uh,
All right. So the patient was started on high dose steroids and then he got discharged. A year later, the patient came back with neck or femur fracture. What could be the cause?
the steroids can cause the avascular necrosis of neck of femur, so that is prone to fracture.
Mm-hmm. Anything else? And why would the steroids cause the fracture?
Because it causes avascular necrosis.
Mm-hmm.
Then
Anything else?
there is immunosuppressant effect. There is wound healing, delayed wound healing, and also
So, any other reasons in addition to the avascular necrosis?
there is osteoporosis, increased risk of osteoporosis because of steroids.
Can you tell me the risk factors for osteoporosis?
It could be primary idiopathic or could be postmenopausal in females, could be due to post-traumatic or hypocalcemia or renal disease or metabolic diseases like Gaucher's disease, long steroid intake, or hypoparathyroidism, or primary primary hypoparathyroidism, secondary hypoparathyroidism, or could be
How about the BMI?
BMI. Yeah, high BMI also can cause
I'm going to
osteoporosis.
stop you there. Can you tell me the pathological changes in osteoporosis? What happens to the bone?
There is thinning of trabeculae with the increased interdigitations, which causes the thinning of bone and decreased bone mineral density.
What are the causes of pathological fractures?
It could be malignancy, metastasis to the bone, primary malignancy of the bone, post radiation, uh, osteoporosis, or secondary hyperparathyroidism, renal uh, renal cause due to renal losses of calcium that can cause pathological fracture, or it could be
It could be.
Paget's disease of the bone, multiple myeloma, leukemias,
So what's the most common one?
metastasis to the bone, and cancer.
All right, I'm going to stop you there. All right, time's up. So unfortunately, there is a bit of section left, which we'll talk about later on. Before I forget, I'm going to let you unmute all of you. So feel free to unmute yourself and then jump into the discussion. All right. So this is a station where we connect the giant cell arteritis and the osteoporosis, and then later on connect to another topic as well. So like all the pathology stations, you won't end up in one, but like at least 2 to 3 minimum. So I'll give you a brief feedback first. So there is a trending, and in fact, this is kind of like quite a standard procedure before the temporal artery biopsy is imaging. So what kind of imaging would you expect to like to do? Pretty.
Arteriogram. Arteriogram.
We do not do arteriogram. It's quite invasive.
Angiography, CT angiography.
We don't do the CT angiogram either, although you can do it, but more commonly,
I think you do temporal artery ultrasound.
or not ultrasound. You're getting there.
Duplex?
Duplex, very good. If it's an well, I'll tell you this, very easy. If it's a vessel, it's a duplex. You can never go wrong. All right. We'll talk about the difference between an ultrasound and a duplex later on as well. And then the next thing is the treatment is methylprednisolone. So it is not really correct because not all patients who present with temporal artery biopsy or are suspicious with temporal artery biopsy go on to the methylprednisolone, all of them. And plasmapheresis is quite controversial. We don't use it at all. And the next thing, the risk factor for osteoporosis. One thing that the examiner can check if you're bluffing or not is asking for the risk factor of the BMI. It is not the high BMI, unfortunately, right? It is the low BMI. That is a risk factor for your osteoporosis because of the links to the nutritional deficiencies for that. So it's a low BMI. It's not a high BMI. 99% of the time, High BMI is a risk factors for all the diseases, but not the osteoporosis. And well, we'll talk about it later on. Right. So my advice to you, Pratia, is that your answers are not concise. So if I ask you what are the risk factors for osteoporosis, you don't need to kind of like explain it to me. Okay, it could be this because of this and this and that. Okay, it could as well be this one, and then it could as well be this one. No. What you should say is the risk factors for osteoporosis. So if the examiner asks you what are the risk factors for osteoporosis, 1, 2, 3, 4, 5, 6. That's it. Stop. If the examiner wants more for that. So usually they would want at least 6 to 8 risk factors. You can't really stop at 3. Osteoporosis is a huge list of risk factors as well. So the same thing. What are the causes for pathological fractures? 1, 2, 3, 4, 5. That's it. And then stop. If the examiner wants more, continue that. Whether you talk about this for 15 seconds, 20 seconds, or even some of the questions you talk about 30 seconds, that question's worth 1 mark. Maximum 2 marks, not more than 2 for the knowledge questions, because there are about 20 questions and then each question carries about 1 mark. So you have to be careful about it. Whether you spend 30 seconds or 2-3 seconds, the answer you get 1 mark. So your answer must be concise and complete in the first instance. If the examiner wants more, they always ask you, they'll always prompt you, okay, why do you think it did this? Or can you give me more? Or they will always ask you about it. Right. So what we're going to do is we'll go through this session together. So as I said, there are 3 topics. Let's start with the giant cell arthritis. I'll show you the I'll share the screen for the portal. So we're going to use the old portal because the knowledge part is not migrated yet. So giant cell arthritis. There we go. So let's start with the giant cell arthritis. What's the gold standard for diagnosis? Anyone?
Temporal artery biopsy.
Temporal artery biopsy. Do you know how long does it take to get a slot for a temporal artery biopsy? It's usually a few days. But on average, there's about 2 to 3 days, of course, depending on the center and stuff. But temporal artery biopsy is never an emergency. Why? Because the management starts way before the diagnosis established to prevent complications for that. So nowadays, by the way, if I ask you to choose one blood test, which one are you going to choose?
ESR, raised ESR.
Raised ESR. CRP could be acceptable as well, but classically for the surgical exams, especially for the surgical and medical exam, classic answer is the ESR, usually more than 50 millimeter mercury. What is ESR, by the way?
Erythrocyte sedimentation.
Right.
Great. Make sure you know all the long forms for these acronyms as well. Right? Otherwise, it will be very embarrassing for the exam. So ESR is correct. More than 50 millimeter per hour is diagnostic of the giant cell arthritis. And then we are going to do the temporal biopsy. But lately, we can do the imaging. So let's have a quick look at it. So routine blood test, ESR, it's the single blood test. I'm going to choose that one. Or CRP alternatively acceptable as well. The duplex ultrasound and the temporal artery biopsy. The duplex, what's the difference between the normal ultrasound and the duplex?
There's a B mode.
So what's a B mode? Anyone? Anyone would like to help? So what is the difference between the ultrasound and the duplex? Or alternatively, the examiner could ask a more common question is, what is the difference between a Doppler and a duplex? Anyone? No? Doppler versus duplex. The normal ultrasound versus duplex, what's the main difference? Why do we use a duplex, by the way?
To see the flow. Doppler will.
Very good. How do you see the flow? Why do you see the flow? And would you see the flow on a normal ultrasound?
No.
No. Why? Because you need to
Because
incorporate the Doppler into the normal ultrasound to produce a duplex. That is the short answer. Right. Imagine if you grab the ultrasound probe and put it on. That is the default B mode, unless you change it to the duplex mode. Nowadays, all the ultrasound machines come with a kind of like a semi-duplex now, even if it's not full mode. So if you put it on and if you put it on the vessel, you won't see anything unless you switch it on the duplex. So duplex is B mode ultrasound, which is the 2D one, the basic one, plus the Doppler. The Doppler ultrasound is the strict Doppler is a handle Doppler that we all know, right? You put on the probe and then you listen to the flow. So the Doppler, it works with something called Doppler effect. Imagine you're standing there and the train passes by blasting the horn. So the horn, you'll start hear it louder and louder. And next to you, the train, you'll hear the sound loudest, and then the sound fades away. That is something called Doppler effect. The same thing, you can do it. You put a probe on the vessel, and that using that one, then you can hear the sound. And if you combined it with the 2D ultrasound, which is a B mode, you get the duplex. And if the flow is flowing, if the blood is flowing towards the probe, we can paint it one color. If the flow is away from the probe, you can paint it another color. Usually the one that going to the flow to the probe is red or the orange. That's why you see the arteries mostly as orange and the blue one as the vein. But it's not always true. Whichever the flow is towards a probe, it's always appear red, regardless of the artery or the vein. So again, that's a quick touch on the duplex. And then temporal artery biopsy, we'll talk about that a little bit more in a minute. So what is the pathophysiology? Sorry, histopathological features. So let's start with the histopathological features. If we take the temporal artery biopsy, what are you going to see?
granulomatous.
Granulomatous inflammation. That's one of the keywords. Anything else?
Intimal thickening.
Intimal thickening, okay. Why is it called giant cell arteritis? Because we're going to
Giant
see giant
cells.
cell as well. Great. So typically shows granulomatous inflammation, intimal thickening with luminal stenosis, multinucleated giant cells, usually in the tunica media. They could be focal and segmental as well. What does it mean? Meaning it could be just a focal lesion of that particular artery, not affecting the whole artery. That's why, for example, one of my bosses, when he taught me how to take the temporal artery biopsy, he always say you must take at least 1.5 to 2 centimeter a length of the temporal artery. Otherwise, you might miss the focal nature of the disease. So if you take the temporal artery biopsy, if you ever end up taking the temporal artery biopsy, keep that in mind. Pathophysiology. So when this happens, what is the problem? What is the result of that problem? So this is the problem. So they are causing the intimal thickening and then the focal segmental problems. So what's the pathophysiology? Why is it a problem?
Will occlude the central retinal artery, branch of ophthalmic artery.
So you are kind of like focused on the central retinal artery, which is correct. It's not wrong, but it's not the main artery that causes the loss of vision. Loss of vision is mainly driven by, we'll talk about that in a minute. Right, there's loss of vision separately. So giant cell arteritis is an immune-mediated vasculature characterized by granulomatous inflammation, as we said. It will lead to expansion and hyperplasia, causing the narrowing and occlusion of the vessel lumen, ultimately causing total occlusion of the artery and tissue ischemia. That's a problem. Unfortunately, giant cell arteritis focuses on to the medium-sized vessel, especially the branches of the external carotids and branches of the internal carotids as well in the head and neck region. So it can affect virtually any vessel, by the way. There are cases where giant cell arteritis affects the aorta, for example, although it's not common. One of the most common thing is causing, affecting the branches of the ophthalmic artery, not the ophthalmic artery itself. Even if you block off the ophthalmic artery, the patient may not have visual loss. Why?
Lateral circulation.
There is collateral circulation, but the branches of the ophthalmic artery, these are called end arteries. What do you understand by end arteries? What
They
are
are
end arteries?
terminal branch. Terminal
These are the
branches.
terminal branches with very little anastomosis. So if you block off an end artery, like central retinal artery you kept talking about, then the patient will end up having loss of vision. It's not the ophthalmic artery as a whole, because if you remember, ophthalmic artery anastomosis with the dorsal nasal artery, right? That comes up from the external carotid through the facial artery here, and there is plenty of anastomosis if it's ophthalmic artery alone. It may not cause it may not be severe enough to cause the visual loss, but it could lead to that. But branches, especially posterior ciliary artery. Posterior ciliary arteries is the most common cause of loss of vision, and this is something called anterior ischemic optic neuropathy, or EON. EON is the most common cause of visual loss in giant cell arteritis, and it's a branch of ophthalmic artery as well. Central retinal artery occlusion, as well as the EON, which are the posterior ciliary arteries. Right. So how do we manage the giant cell arteritis?
Hydrosteroids.
Hydrosteroids. Which one?
You give prednisolone.
Methylprednisolone.
Prednisolone or methylprednisolone? What's the difference?
I think you give prednisolone oral dose, a long-term course. Then if there's involvement of visual loss or MRCS focus, that's when you give methylprednisolone IV.
Methylprednisolone is the IV preparation. Prednisolone is the oral preparation for that. So we start with a high-dose oral corticosteroids. Mainly, it's a prednisolone. If the patient has got focal neurological deficits, that includes a loss of vision, having seizures, all of these things. If that's the case, we switch to initially high-dose methylprednisolone. Once the patient gets better, we switch it to the oral and continue long-term, and then discharge the patient home. And if it's refractory, if it's severe enough, what else can you give? Immunomodulators like methotrexate, for example. But nowadays, we've got immunotherapy pretty much everywhere. Right? So we give anti-IL-6 monoclonal antibodies. So let's have a look at. So high-dose prednisolone orally should be started before the confirmation of the diagnosis with a gold standard diagnosis, temporal optic atrophy. As we said, it's going to take a few days. So we cannot wait for the diagnosis. The patient will be blind and it will be permanent. We cannot reverse the blindness. So to prevent patients getting blind, we have to start treatment before confirmation of the diagnosis. Next, IV preparation is used if it's severe enough to cause visual loss or physiological problems per se. And tocilizumab usually is the first line as an anti-IL-6 or methotrexate with the refractory or relapse of the disease. That is pretty much for the giant cell arteritis. And then we're going to have a quick connection switch to the topic. So let's say the patient goes home with the prednisolone, got discharged. And then after a year, the patient came back with neck or femur fracture. What's happening?
Osteoporosis and avascular necrosis.
Avascular necrosis. These are the two main driving causes. These have got very separate mechanism of action. So osteoporosis takes a bit of time, and it's due to the osteoblast deactivation, osteoclast overactivation, leading to the bone resorption and that ratio imbalance, leading to osteoporosis sooner or later. Steroids alone can induce avascular necrosis as well. That is affecting the vessels, cutting off the blood supply to the neck or femur fracture. So we can talk about this one. So starting with the osteoporosis, what is the problem with the osteoporosis? I just briefly mentioned about it, but what is the main problem with the osteoporosis?
Demineralization of the bone.
Decreased bone density with normal bone mineralization.
So bone structure is normal, but the bone is losing the mass. However, if you look at under the microscope, you might see the microfractures and stuff, but usually architecture is intact, but it's get thinner and thinner. The problem is if the bone is not strong enough, it's going to cause fractures. That is one of the main problems. So before we talked about the osteoporosis, we need to look at the normal bone remodeling. How does the bone remodel itself? So let's quickly go through this together. The osteoporosis is a complex skeletal disease characterized by the low bone density, microarchitectural defects. So usually, if you look at the bone architecture, it's usually intact and it's only getting thinner and thinner. So normal bone remodeling, how does the bone remodel itself? Because it's a dynamic, continuous process and it happens all the time, whether there is a pathology or not. And it usually starts with the resorption of the osteoclast. So if the osteoclast will come and remove that bone and then leave a small depression or the lacunae, where later on osteoblast came and then filled that in. And that is how remodeling happens. Remodeling is continuous in a way that every 10 years, the bone in your body is completely remodeled, meaning your bones right now, it's not the same as the bones that you had about 10 years ago. So every 10 years, around about 10 to 15 years, every bone in your body is remodeled. If that remodeling is decoupled, if there is any problem with it remodeling, for example, if it's coupled in the temporal and spatial coupling, what we call it. Temporal is the timing. So if the osteoclast will come and remove the bone, but osteoblast taking longer to come and deposit the bone, osteoporosis will happen. Or it happens at the same time, but spatial coupling is decoupled, meaning different spaces. Osteoblast go and deposit the bone somewhere, osteoclast take the bone out somewhere. Again, osteoporosis happens. So any defect that leads to disruption of the normal bone remodeling will lead to osteoporosis. So the risk factors, being a female, old age, low BMI, again, this is the examiner's favorite. If the examiner thinks you're bluffing, you're just taking out a lot of things, and if the examiner thinks you are kind of like, you really don't know the topic, they'll ask you about the BMI. And 90% of the candidates will say, oh yes, high BMI is a risk factor. Well, normally you'd be true 90% of the time, but unfortunately, this is not. Family history, post-menopausal, smoking, alcohol, immobilization, corticosteroids, usually the long-term high dose, calcium, hypocalcemia, and vitamin D problems like chronic kidney disease, for example, or hyperparathyroidism for these, or the hypoparathyroidism as well. And the pathological changes or the hallmark is normal bone that is decreased in quantity. The trabecular plates become perforated, thinned, and lose their connections, leading to microfractures. So the cortex thin and the osteohavation systems are widened. As a result, the bone gets spongier and spongier. Sooner or later, it won't be able to hold, for example, the weight. That's why neck or femur comes at an angle and causes the fracture even with a minimal trauma. So that is pretty much it. So there is a separate osteoporosis station. So I'm not going to go through the rest of these things. But I'd like to ask one more question. What are the causes of pathological fractures? Anyone?
Split into malignant and non-malignant causes. So malignant causes would be bone tumors or metastases to the bone. And then non-malignant causes could be things like osteoporosis, osteomalacia, vitamin D deficiency, renal failure, calcium deficiency.
So what do you think is the most common? What's the most common cause of pathological fractures?
Osteoporosis.
Of course, osteoporosis. We're talking about osteoporosis, all right. So the tumors, mainly metabolic and the tumors are the two groups that can cause it. Primary benign, primary malignant like osteosarcomas, or primary benign, that's a bone cyst, or the secondary metastases that could lead to the pathological fracture. So this is pretty much a malignancy. And then metabolic causes, Paget's disease, hyperparathyroidism, osteoporosis, etc. can lead to pathological fractures as well. So let's say this patient now has broken neck or femur, came in, so you need to operate, obviously. So what will be a concern? What is your concern operating this patient?
Weak bone, less
I
bone
think we're
mineral
concerned
density.
about who are healing.
No. If you miss this one, you're going to kill the patient, by the way. We're not worried
Fat
about the
embolism.
bone. That's a hint for you. We are not worried about the bone.
Fat embolism.
No? Anything else?
The patient's on steroids, possibly Addisonian crisis.
Very good. Addisonian
Addisonian
crisis.
crisis.
If you
Yes.
miss Addisonian crisis, you are going to kill the patient. Why? Talk about it in a minute. So what is Addisonian crisis?
Sudden withdrawal of steroids will cause body will not compensate the sudden withdrawal of steroids. So there will be decreased corticosteroid level in the blood.
So in this case, there is no sudden withdrawal. So your definition is not quite right, is it? So in this case, we're not stopping.
We already have chronic suppression of the adrenal, so it can't be.
So tell me a complete definition of what is Addisonian crisis.
It is a state where the body is not able to tolerate any stress due to the chronic suppression of the adrenals.
So this is insufficiency. But Addisonian crisis, it happens because of the insufficiency, meaning inadequate amount of glucocorticoids available. Meaning, if the patient is on long-term steroids and something happened, stress events, could be severe infection, it could be trauma, it could be surgery, it could be myocardial infarction, it could be a massive stroke. If that happens, then the body needs a lot more to respond to that stress event because glucocorticoids are one of the main responders in the stress event. If the body needs more and if they can't get it, what's going to happen is Addisonian crisis. What are the symptoms of Addisonian crisis?
Hypotension, shock.
It's a form of distributive shock.
It's a profound shock. Shock as in very profound shock. All the symptoms of shock, but nothing responds, not responding to the fluids, not responding to the pressors, and it's very difficult to manage as well. So we'll talk about this one. So why does it happen? Again, we'll talk about it. It's a potentially life-threatening medical emergency of acute adrenal insufficiency. So the signs, if we are to go into, say, one word, that's a shock. They will have profound signs of tachycardia, vasoconstrictions, postural hypotension, oliguria, confusion, coma. If you don't treat it, patient's going to die. Death will be the next. So increased risk in patients with Addison's disease. Obviously, that's where the word come from, Addisonian crisis. Addison's disease is, by the way, what is Addison's disease?
It's a chronic insufficiency of the adrenal.
Primary insufficiency of adrenal cortex. And what causes it? What's the most common cause of Addison's disease?
Autoimmune.
And second most common, especially in the developing world?
Tuberculosis.
Infection. Very good. It's the tuberculosis disruption of the cortex. Right. All the patients taking high dose of prednisolone for more than 4 weeks and a long-term glucocorticoid stop within a year. So the usual example I give is that you've got a car. So you decided to park the car in the garage for 2 years. One day you wake up and then, okay, I'm going to drive the car for 2,000 miles, for example. Do you think it's going to work? The answer is no. Same thing here. When the patients start taking glucocorticoids, it parks the adrenal gland, telling the adrenal gland will buy the negative feedback. Don't need to walk anymore. And then adrenal gland undergoes atrophy. And then one day, patient wakes up, that needs a lot more glucocorticoid than the patient's taking. Do you think the gland's going to produce more? No, they can't. As a result, the patient goes into Addisonian crisis. So, what do you do? What do we do?
We need to do steroid cover protocol.
So what we do is simply we give what's missing, steroids, usually IV hydrocortisone. So you start with the induction of the hydrocortisone, And then every 8 hours, you give it until the patient gets better. Usually minor procedures, you don't need to give anything at all. But moderate procedures, then you have to start with the induction and then every 8 hours for a day or two, and afterwards you can step down back to the oral dose. But this case, a neck or femur fracture or major trauma cases and major procedures, like, for example, nailings or fixations or even hip replacement surgery, for example, these all are major procedures, and you would need, how long would you need to give IV hydrocortisone?
We should give it at induction and after the operation. It depends on the pre-operative dose of cortisone.
It's always 100 to 200 milligram. So how long are you going to give? 1 day, 2 day, 3 day, 4 days, a week, a month?
Oral blood.
The short
If the
answer
patient
is
is able to tolerate oral again.
the short answer is as long as required. All right. So depending on how the patient does post-operatively, if the patient's doing very well, then after 3-4 days, you can taper it down back to the oral dose. That's fine, completely fine, without any of the complications the patient required. But the patient recovery is prolonged or had any of the complications, then you have to continue giving this as long as required. So this is the second part of the station, and the last part later on, the patients having rushes and getting confused. What's happening after the surgery?
Fat embolism.
What is fat embolism? What's a triad?
Release of fat globules into the circulation due to
What is
long
a
bone
triad?
fractures.
Tell me the triad of the
Confusion.
fat embolism. Confusion.
Ecchymosis, then breathlessness.
Say again.
Dyspnea, confusion, and ecchymosis.
What's the third one? I couldn't hear it.
Ecchymosis.
Ecchymosis is the same as the rush. Rush.
Yes, rash.
Confusion and
Dyspnea.
dyspnea. Very good. Hypoxia. Right. Hypoxia, confusion, and petechial rash. These are the things. So when the fat globules are released, usually with the surgery involving the pelvis and the long bone, surgery and trauma, both, releases a lot of fat globules. They go and clog up the capillaries in the skin, causing petechiae. Goes and clogs up the pulmonary circulation, causing hypoxia. And then they goes and clogs up the neurological circulation, again, causing the cognitive decline, causes the confusion stuff. So the triad is hypoxia, confusion, and petechial rash. Due to the presence of fat emboli in the systemic circulation after long bone fracture, most commonly, or other major trauma, including crush injuries and burns as well. So what are the causes? So, well, we kind of like listed the most common ones. Tell me a bit more. What are the most common causes?
Long bone fracture
Mm-hmm.
and orthopedic surgeries,
Mm-hmm.
such as intramedullary nailing and fixation.
Yep. Anything else?
Major burns.
Mm-hmm.
Acute pancreatitis.
Right, pancreatitis, for example, although rare, can lead to very severe pancreatitis, can lead to fat embolism as well. So the most common ones are surgery and trauma that involves the long bones, especially the femur and the pelvis. This is the very common side of that. Non-orthopedic trauma, so injury to the adipose tissues like severe burns, liposuction procedures, and the bone marrow harvesting for the bone marrow transplant procedures as well. And the non-traumatic causes pancreatitis, diabetes, fatty liver disease, and lipid infusion. But in some cases, we have to infuse the lipid. What kind of cases do we infuse lipid?
In case of toxicity of local anesthesia.
And why do we infuse lipids?
As antidote for local anesthesia.
Why lipids? Because
it bends to the local anesthesia and excreted.
Very good. Because local anesthesia agents love the lipids. So that's why we infuse the lipids, they go and bind it and then eventually clear it out. If we don't give it, they're going to go and bind the lipid membrane on neurons and cardiomyocytes and causes a lot of problems. That's why we give 20% lipid infusion in severe causes. Of course, we don't start with the lipid infusion. And the management of fat embolism syndrome, how do you manage it?
Supportive.
Mainly supportive management, in which you give oxygen, make sure that the patient is oxygen, ventilator support if it's severe.
We flow
also
ABCDE.
So
Yes,
what you
yes.
said is correct. It's the A2 assessment, conservative management, and supportive treatment. So supportive of the triad that we talked about it. Hypoxia, then we have to give respiratory support. And then if cardiovascular support require IV fluids plus minus inotrope plus minus presses, renal replacement therapy, especially if there are a lot of severe cases, then you put the patient on hemofiltration, which will eventually filter out these droplets as well. In ITU setting, we use hemofiltration. In community settings, we mostly use hemodialysis. These are two different things, but umbrella term is renal replacement therapy. They are very similar. Hemofiltration uses a filter. The blood is forced through the filter. And on that is something called convection method. Hemodialysis, on the other hand, there is a semi-permeable membrane and the fluids moves in opposite direction and some of them permeates through the semi-permeable membrane. That's the difference between the hemofiltration and hemodialysis. Dialysis is very good at removing the volume, whereas the hemofiltration is very good at removing the solute, but both remove both the volume and the solute anyway. So controversial options are steroids, aspirin, heparin. They are controversial. Some centers use it, some don't. There is not enough evidence behind these. So this is pretty much of the first station. Do you have any questions? Right, so why don't we move on with the second station? Great, so we offer subscription, so if you're interested, come and join us. Right, we sit down and talk to every station like this. The next, Ahmed.
Yep.
So what I'm gonna do is gonna mute all of you again. Gonna set the timer. Here we go. All right. So I will be your patient. So take me through the process.
Good afternoon. My name is Ahmed Ibrahim. I'm one of the surgical doctors. Can I just start off by confirming your full name and date of birth?
Hi, my name is Kate. I'm 19th October 1979. So assuming it's 40 years.
And what would you like me to call you today?
Call me Kate.
Okay, Kate. So I've been asked to carry out an abdominal exam on you because I understand you've been having some tummy pain. What that's going to include is me just having a general look at you from the bedside, and I'll start off looking at your hands, working my way up to your face, and then finally having a look at your chest and tummy. Okay?
Okay.
So you will have to expose a little bit of your chest and tummy for the examination. But we'll have a chaperone with us today, if that's okay.
Right, yeah.
Do you have any questions or concerns before we start?
No, doctor.
No? Okay. So I'll just have a general look at the patient from the bedside, looking at their body habitus, and then have a closer look. So I'd like to start off with their hands first of all. So Is it okay if I talk you through it? I'm assuming it's a bit hard to.
Yep. So
Yep.
tell me what you're looking for in the hands.
Yep. So initially, I'll look at the hands, looking for any signs of palmar erythema, any obvious scarring or swelling. And then I'd ask the patient for clubbing to do the clubbing sign. And while I'm here, I could also feel for the pulse as well. And then I'd ask the patient to stick their hand out, looking for any signs of a flapping tremor, and cock their hands backwards. And if I want to try to elicit the response a bit more, I can press down on the hand as well to make it more prominent. I'd work my way up the arm, looking for any possible track marks if I'm suspecting an IVDU drug user. And then I'd look at the eyes, looking for any signs of corneal arcus or possibly any jaundice as well. Open the mouth, looking for any central cyanosis. Stick your tongue out for me. And then I'll make my way to the neck, where I'd have a feel for the lymph nodes, specifically the Virchow's lymph
So
nodes.
I'm going to stop you there for a minute. In the mouth, what else are you looking for in addition to the central cyanosis?
In the mouth, I'm looking at also the mucous membranes if they're dry as well.
Anything else?
Possibly any macroglossia. I'm not too sure.
All right, please continue.
Okay, yeah, and then I'll do a cervical lymph node examination, feeling for the Virchow's lymph node, and then moving on, I'll politely ask the patient just to see their chest and looking for any signs of spider navi. If it was a male patient, possibly gynecomastia as well. And that's fine. And then I can cover their chest again, and then I'd like to move to the abdomen. At this point, I would make sure the bed is flat, and then I'm just looking at the abdomen at eye level. I can ask the patient to cough and possibly flex their neck to elicit any signs of any pain. And then before pressing on the tummy, I would ask the patient where their pain is, and then I'll
So the
start.
patient tells you the pain's in the right hypochondriac region.
Right hypochondriac. So I'll start from the opposite side with light palpation and make my way towards it, and then see how they are. I'll possibly offer them some painkillers or if required. And I'll then ask the patient if it's okay for me to do deep palpation.
So when you pressed on the in the right hypochondriac region, the patient says, "Doctor, that's a bit painful."
Mm-hmm. So I'll say if it's okay with you, I'd like to press a little harder now and see how they respond to that, if they allow me to do it or not. If not, that's fine. I wouldn't do it.
Okay, so the patient allows you to press harder. So what are you going to do?
So I'll press harder on the 9 quadrants, and then I'd like to also do Murphy's sign while I'm there in the right upper quadrant in the right hypochondrium. I then also want to.
Can you describe Murphy's sign?
Yep. So I'd ask the patient to take a deep breath in, and then I'll press down on the right upper quadrant or the right hypochondrium, and then they'll breathe out, and then it should elicit more pain than before. And then moving on from that, I'd also like to palpate. I won't palpate the kidney, the liver at this point because the patient's in right upper quadrant pain, but I'll palpate for splenomegaly still. I'll then also like to palpate the kidneys, block the kidneys, and then also palpate for any possibly aneurysm as well, AAA while I'm there. If the patient has signs of ascites, I would percuss as well. But if there's no signs of ascites, there's no shifting down there. So I can just percuss for splenomegaly and then also for over the bladder if I'm worried about urinary retention. Finally, I'd like to auscultate. So I'd listen to bowel sounds if they're present. And then I can listen to any bruits as well. So ileal bruits, renal bruits, or aortic bruits as well. Finish off the examination. I want to look at the patient's legs for any signs of swelling. And then that'll be the end of my examination, and I'll summarize my findings to the examiner.
All right, please summarize the findings.
Yep, so today I've examined Kate, a 40-year-old lady that's coming today with some right upper quadrant pain.
Sorry, I've got to tell you, she's got Murphy's positive.
Murphy's positive, okay. On general inspection, the patient has a larger body habitus and no obvious pathology seen in the peripheries. However, on closer examination of the tummy, there was initially some right hypochondrial pain, and Murphy's sign was positive in this patient, and no other positive findings were found. Overall, the abdomen was soft, and no other positive findings. My top differential here would be possibly a cholecystitis, but also differentials include gallstones or cholangitis or pancreatitis.
Right, I need 5 differentials. So cholecystitis, gallstones, pancreatitis, 2 more.
Yep, cholangitis, and then also non-GI causes would include things like renal colic or possibly endometriosis.
Which investigations would you like to do?
Yep, so first of all, I'd like to get some bedside investigations for the patient, looking at their new score following on from this, I'd like to get basic bloods from the patient, so full blood count using these LFTs, and also CRP looking for any signs of inflammation, and LFTs focusing on ALP, ALTs. I'd then also like urine dipstick if I was just to exclude any causing possible UTI if I was worried. And then also imaging, I'd like to start off initially with an ultrasound scan, abdomen, and then make my way up from there.
What if ultrasound's not conclusive?
So if ultrasound's not conclusive, I'll move to another non-invasive method such as MRCP if I was worried about the biliary tree and keeping the LFTs in mind as well, if the results are back.
Have you ever heard of HEDA scan?
I've heard of it, yes.
What is HEDA? What does it stand for? And what is
I've
it?
I've just heard of it. I'm not too sure about the
Let's say MRCP is not conclusive. Anything else that you can do?
a HETA, apart from a HETA scan? No.
Yeah, apart from that.
Possibly an ERCP would be more invasive, but an ERCP. Or also CT abdomen, sorry, CT abdomen.
Anything else?
So ultrasound, CT abdomen, MRCP.
All right, so tell me the management of acute cholecystitis.
So management would first, depending on the patient, would be initially conservative. So I'd like to stabilize the patient following the care of the critically ill surgical patient. So doing an A to E. Once I'm happy with stabilizing the patient, I want to start the patient on broad spectrum antibiotics while waiting for the blood cultures to come back, following my hospital guidelines and also discussion.
So give me an example of antibiotics.
Yeah, so usually we can use third or fourth generation cephalosporins and then also metronidazole as well for broad spectrum cover and cholangitis.
Which organisms are you targeting?
Some gram positive, gram negative, and anaerobes.
What's the most common organism?
E. coli.
Okay, please continue.
Yep. So starting off, and then I want to list the patient if there's a gallstone present or not. I'd like to list the patient for either an early cholecystectomy, or if the patient's unfit and unwell and unable to tolerate a procedure, then possibly speaking to my interventional radiologist and putting a percutaneous cholecystostomy if the patient does not improve with conservative management. I want to monitor the patient and see how they get on as well. Alongside that, yeah.
So the patient had surgery. Later on, the patient was found to have deranged liver function test. What do you think's happened?
Yeah, so it could be multiple causes. So it could be a retained common bile duct stone. It could be possibly a stricture, or it could be due to damage during the operation causing a bile leak, or yeah, those would be the most common causes.
All right, time's up. There's one more question. Anyway, I'll let you answer it. So what is the next step? So that was the last question.
That was the next step.
So next step for this patient with a deranged liver function test post-operatively.
So I'll do an ERCP and explore looking for any retained stones or any slipped.
I want to take the patient to ERCP straight away, is it?
So initially I'll do an MRCP, sorry, first to look at the
ultrasound
and
MRCP. MRI first.
Yeah, so I'll monitor the LFTs if they improve conservatively.
They won't improve conservatively. You need to do something. So what is imaging? What's the first line imaging? That's a question.
MRCP. Oh, is it ultrasound then? Ultrasound, sorry. Yeah.
First line is the ultrasound. The best is the ERCP because it's the diagnostic as well as the therapeutic as well. Right. So before I forget, I'm going to unmute all of you. So feel free to mute your mics and jump in the discussion. I'm going to give a brief feedback before we move on. So Ahmed, I think you didn't mention to wash hands. I'm sure you might probably wash your hands, but with the exam pressure, you're going to forget it. So it's a free mark. Don't throw away it. It's, assuming you're not washing your hands in 5 stations, and you're going to lose 5 marks for nothing. Then the next thing is for example, in the mouth, we are not looking for central cyanosis. This is no cardiovascular examination, although you can have a quick glance at it. But more commonly, we're looking for glossitis, stomatitis, hygienes, as well as the oral candidiasis. These are the common findings that we look for in the oral examination, for example. And then the Murphy sign is not, the positive is classically not described as the pain, more pain. It classically described as when you pressed onto the right hypochondriac region, the patient stops breathing because of pain. So that's the you ask the patient to inhale inspiration, and then it stops mid-inspiration. That is usually the classic positive thing. And well, why don't we go through this station together? Right. So I'm just going to load up our new portal. There's the old one. So great. So abdominal examination, obviously, this is one of the very common and probably the first examination that we learned in medical school, yet we always struggle to do it perfectly for some reason. So let's quickly use the interactive mode first. So introduction, as usual, don't forget to wash your hands, explain, take consent, and there are a few examinations where we have to do it in a bit strict position. So this is one of them. You must do abdominal examination in a supine position, right? And for example, what other examinations have got strict positioning? Tell me two more.
Breast 45 degrees, semi-incumbent.
Say again?
Breast and then semi-inclined position.
Well, not necessarily the breast. Some people do it 45, some people do it sitting. Well, you can't. There is no
Cardiac
strict positioning, mostly. One is cardiovascular, the other one is respiratory, by the way. So you must do it in 45 degrees. And for the purpose of the exam, that's very important. In reality, except the tubular venous pressure, you can do it pretty much comfortably in line position as well. But for the purpose of the exam, you must do it in 45 degrees. Otherwise, you might lose a mark or two. Right. So we're going to start with the general inspection. Again, there are certain examinations you cannot finish with a general examination, like abdominal examination, cardiovascular, respiratory, and as well as the thyroid examination. But general examination must be done. So we're going to start looking at generally if the patient's cachectic, if the patient's got jaundice, if the patient's got pain or discomfort. If that's the case, then we're going to express sympathy and empathy, and then we can offer some analgesia, for example. And then hands and the arms. So we're going to look at what are we going to look at in the hands and the arms?
Palmar erythema, defensive
Right. So the important thing is don't start talking about splinter hemorrhages, Osler nodes, and Janeway lesions. This is the abdominal examination. And then vice versa, cardiovascular examination. When you're doing a cardiovascular examination, you can't start talking about colonychia, leukonychia, and all these pulmonary erythema and stuff, because that's not what we're looking for. So keep that in mind. You do not need to verbalize the examination that you're doing. You just need to look at face and the hands afterwards, and then the face later on. We'll talk about it. But sometimes the examiner will stop you and ask, okay, what are you looking for? Then you should be able to list a few things that you are looking for. So often the examiner will stop you and ask you, and to make sure you're not bluffing, or especially if they think you're bluffing, they'll stop you and then ask you about this as well. So nails, colonychia, for example, spoon-shaped nails, or the leukonychia, white patches, usually due to liver disease and hyperalbuminemia, and the clubbings, as I said, caused by lots of diseases. Pulmonary erythemas, Dupuytren's contractures, hepatic flaps, or the asterexis, that is a flapping tremor. Ask the patient to cock the wrist back for a few seconds, and then check the pulse while we're at it. And then in the face and neck, what we're looking for?
Jaundice, pallor, hair loss, arcus senilis, xanthus.
In the neck?
Cervical nodes.
Which node?
Particularly? Left supraclavicular.
Very good. Don't forget the Voco's node or the left supraclavicular node, particularly in the abdominal examination. That's, again, one of the commonly missed one, by the way. That's usually 1 mark. So don't throw away that 3 mark spot. So inspecting the eyes, you can see the icterus or the pallor. You always ask the patient to do it. Do not do it yourself, right? Don't touch the patient unless you really need to. And do not say the patient's got anemia. Anemia, by definition, is the reduction in the hemoglobin. You can't see the hemoglobin by checking the conjunctiva. Then you may see the case of Fisher rings, but it's in the Wilson's disease, the position of the Cochrane stuff. And then mouth, you can look at the angular stomatitis, glossitis, ulcers, and well, the breath order it's not very important. And what's important is supraclavicular left, supraclavicular lymph node, Voco's node. And the chest, again, we'll quickly go through this, not very important, spider nevi. and the gynecomastia, especially in the males, and have a quick glance at the axillary hair as well. So the inspection itself is the abdominal inspection. As we all know, we must position the patient supine position, and then look for the scars, if there is any distension, any caput any of the visible peristalsis, especially for the very thin patients, and ask the patient to give a big cough and observe the hernial orifices. Although hernias may not happen while the patient's lying down. And the palpation, we're going to do the light and deep palpation. So first ask the patient, have you got any pain? And we have to start strictly away from the pain. What you don't want to do is start with the pain and put the patients in very discomfort, and that's going to not go well, because it will eventually mask the positive finding that you may find later on as well. So ensure hands are warm, maintain the eye contact while you're doing the palpation, especially palpation part. Again, that's very common mistake by the candidates. We all know when we go into field, we need to look at the patient's intermittent eye contact, but most of the time, 90% of you, what you're going to do is look at the area where you're palpating with the exam pressure and stuff. So don't do that. Sometimes candidate instructions, not the candidate instructions, I beg your pardon, the actor instructions specifically tells the actors that they just change their face a little bit because of the pain or the discomfort. Do not say anything. And that might as well be the only positive finding in the whole station, and you might miss that. That's why it's important that you always have a quick glance at the patients while you're doing the palpation. Then the next specific organs, palpate the liver and the spleen. Again, both starts from the right iliac fossa, and then liver goes to the right hypochondriac region, whereas the spleen goes to from the right iliac fossa diagonally towards the left hypochondriac region. If the patient is really painful, especially in the right hypochondriac region, you might as well skip the liver palpation and stuff. And then you can block the kidneys. Again, you might skip on the right side and have a quick feel of the abdominal aorta. In this case, not very important. So if the patient's too much in pain, you might skip, or you might ask the patient, can you bear with me? I'm just going to press a little bit deeper. And the percussion, again, liver, spleen, and the bladder, especially if the patient comes to urinary retention, then you may percuss the bladder and see if there is any dullness, then the bladder might be really full for that. And shifting dullness is the main thing that you need to look for the typical abdominal examination. This is that you start in the midline, and then go to one side, doesn't really matter which side, and then you percuss it until, what is the normal sound?
There's a tympanic.
Tympanic, I think it's wrong here, right? It's a tympanic sound, and then it will disappear and become dull. At one point, it will be dull. You ask the patient to turn to the other side. So if you come down towards you, you ask the patient to turn to the other side, and then wait for a few seconds. Ideally, you have to wait for 30 seconds, and then because again, if it becomes tympanic again, that's not good, because that means there is a lot of fluid accumulating in the patient's abdomen, peritoneal cavity, and now it's clears and you are tapping into tympanic sound again. It should be dull, continuous dull. And then auscultation part. So auscultation part of the, you listen for the bowel sounds, usually 1 or 2 quadrants, that's enough. Do not say if the bowel sounds are absent, do not say absent, because you need to listen for at least 3 minutes to say bowel sounds are absent. But if you can hear it, you can say, okay, bowel sounds are present, and then you move on. And the renal bruit and the aortic bruit as well. Special test for all the upper abdominal pain, you should do the Murphy's. Murphy's is you press onto the right hypochondriac region and you ask the patient to take a deep breath in. Why do you ask the patient to take a deep breath?
To elevate the gallbladder.
Doesn't do anything to the gallbladder. It does the
movement of the diaphragm will cause movement of gallbladder and the rotation.
Inspiration meaning filling up the lungs. If the lungs are filled up, it pushes the diaphragm down, meaning diaphragm will further push down the liver, and the liver will further push the fundus of the gallbladder a little bit outwards and forward. When you're pressing it, the gallbladder fundus, irritated one, will meet somewhat midway, and that causes too much of the pain that the patient had to stop breathing. That is the very basic of the Murphy's and the classic description of that. And the Rosings, especially if you're worried about appendicitis, acute appendicitis, then you press on the left iliac fossa and the patient says, okay, I've got pain on the right iliac fossa. That's a roasting sign, and that is due to the irritation of the parietal peritoneum. And then the rebound tenderness, again, the same thing. So tenderness is when you press it down onto the abdomen. And the rebound tenderness when you remove it, and the patient will have more pain, again, because of the irritation of the peritoneum. The completion of the examination, thank the patient, and then do not leave the patient exposed. And then when the bell rings, okay, you move to the examiner, and then don't leave the patient exposed. Very, very bad. And that is, again, very common mistake for the candidates as well. Take your time, say thank you to the actor, and if required, you need to put the blanket over the actor as well, and then move on to the examiner calmly. Right. Remember, these examination stations are marked 12 marks and 8 marks, 2 domains. Usually there are 2 examiners. One examiner is a medic, the other examiner is a lay examiner. Lay examiner will be looking at 2 things. One, communications, that carries 4 marks. How clear you communicate with the patient. If you keep doing, okay, can you do the flexion, extension, abdomen, all of these things. If you keep saying these jargon, then you're going to lose 4 marks for communication. If your communication is not clear, you're going to lose it. Or if you're not communicating at all, just doing whatever you want, then again, you're going to lose that 4 marks as well. The next 4 marks is professionalism. If the patient says, doctor, that's painful, then you have to express your sympathy and empathy. I'm sorry. Because, by the way, when we are examining this patient, we took verbal consent at the start. And, doctor, that's painful, meaning that is the, you don't have the consent of the patient anymore. That's a withdrawal of the consent. Consent could be verbal, or consent could be behavioral as well, not only written. So you have to take the consent again. Is that all right if I continue? Of course, in the exam, the patient will say, yes, please continue as well. Right. So follow-up questions. Cholecystitis. So give me differential diagnosis. How many differentials do you need?
5.
Generally, you have to know 5. If the condition's not very common, then they might accept 3. But the general rule is you have to know 5 and make sure that 5 differentials have got variety. Don't stick to the itis. Well, I can list hepatitis, cholangitis, cholecystitis, all the itis. It still fits, but the examiner won't accept it. So tell me. So we'll start with the acute cholangitis.
Acute cholangitis,
Hepatobiliary, acute
pancreatitis,
cholecystitis, cholangitis, hepatitis, pancreatitis, liver abscess, gastrointestinal, peptic ulcer, subphrenic abscess, renal causes, ureteric stone, and musculoskeletal causes, rib fracture or muscle strain. And we have also medical causes such as the acute pyelonephritis, MI, and right lower lobe pneumonia.
Very good. From the chest, for example, you can include the pneumonia and the MI as well. But my advice to you is that you don't need to list 20 causes. Whether you list 5 or the 20, you're going to get 1 mark. Fine. However, what you're going to use the time is about 3 times more if you're going to use a list only 5 or 20. The other common mistake is that, what's a differential diagnosis? Oh, okay, my differential diagnosis is because the patient's having right hypochondriac pain. I think it's the acute cholecystitis. And then because of this and this, and you don't need to explain about it. What is your differential diagnosis? 1, 2, 3, 4, 5. That's it. What's the investigation? Again, the same thing. You don't need to explain unless the examiner talks to you and asks you. What's your investigation? 1, 2, 3, 4, 5. How would you manage it? 1, 2, 3, 4, 5. The same thing. Unless the examiner stops you and asks you. Remember, time is gold. And you have got very limited time in the exam. If you start to waste, then you will not finish the the questions, follow-up questions. So acute cholecystitis, biliary cholangitis, acute pancreatitis, peptic ulcer disease, pneumonia, hepatitis, and even myocardial infarction that you can include it. Investigations. The rule of the investigation is very simple. You must include the most important investigation for this. If you do not include it, you're not going to get the mark. So what's the most important investigation here? What's the investigation of choice?
Ultrasound.
Of course, ultrasound. Any of the liver pathology, any of the gallbladder pathology, the first line is the liver ultrasound. It's very good. You don't need any of the ionizing radiation, and you can see clearly as well. But my approach, again, is you start with the bloods and then go more aggressively towards the others. So one, starting with the full blood count using ECRP, LFTs, coagulation, and a group and save. Then if we talked about the pancreatitis in the differentials, then you can say amylase or lipase to rule out the acute pancreatitis. Right upper quadrant ultrasound, especially, and you can also do the sonographic Murphy's. So that is rather than using your hand, the probe, you use the probe to press it down, and then it will confirm acute cholecystitis. If it's not conclusive, usually the second line is the HEDA scan, although it's not really readily done nowadays. What does HEDA stand for?
H-amino diacetic acid.
Say again.
Aminodiacetic acid.
What does H stand for? Hepatobiliary. All right. Don't overthink. Hepatobiliary immunodiacetic acid scan. It's a type of
Nuclear imaging.
the nuclear scintigraphy. It's a type of nuclear scintigraphy, and you look at if there is any blockage. For example, if there is a defect of the filling, then probably cystic duct obstruction, etc. And then CT abdomen or the MRI. The next step, which is not here, written here, would be MRCP, which kind of like captures pretty much everything. But if the examiner wants to push you further, what if MRCP is inconclusive? What's next? Last step. It's an invasive imaging, by the way.
ERCP?
Yes,
No? So cholecystitis, ERCP is used to visually look at what's inside the lumen. You can't possibly go and look at it. Well, you can possibly go inside, look at it. That's going to be a bit of overkill. So EUS, by the way. What is EUS?
Endoscopic.
Endoscopic ultrasound. Endoscopic ultrasound is the best. Remember, ultrasound is the best for hepatobiliary imaging. So if you can't put the probe near, then what you do is you put it in and then put it near the probe nearer to the structures, and then you can clearly evaluate it. So endoscopic ultrasound is usually the last one before you move on to the invasive ones, which is the ERCP therapeutic diagnostic, so the therapeutic one. But ERCP is mainly used for biliary complications like decompression of the biliary tree, as well as the putting a stent in, etc. What's the management of acute cholecystitis?
At first, if the patient is in sepsis, I'd like to see the CBC and vitals of the patient. Then I'd like to resuscitate them with IV fluids and antibiotics.
So which antibiotics are you going to use?
I'd like to use broad spectrum antibiotics, ideally, and usually what's used is third generation cephalosporins and metronidazole.
Mm-hmm.
Then after stabilization, if the patient presents within 72 hours, I'd like to go for an immediate cholecystectomy, laparoscopic immediate cholecystectomy. If the patient presents after 72 hours, then I would prefer to go for an interval cholecystectomy after 6 weeks.
Anything else? That's it, the patient's not fit for surgery or very complicated one.
Then I'd like to go for an image-guided percutaneous cholecystostomy.
And who do you call?
Sorry?
Who do you call?
Interventional radiologist.
Interventional radiology. It's no Ghostbusters, all right? Who do you call Ghostbusters now? So management. So you start with that A2 assessment, nearby mouth, adequate analgesia, and then IV antibiotics. So remember E. coli, biliary, urinary tract, and the bowel. So think of 3 Bs as the E. coli. Klebsiella, Pseudomonas, Enterococci, all could be there, but most common is the E. coli. So normally it's the third generation cephalosporins and metronidazole is the choice. Definitive surgery is, of course, we have to do the laparoscopic cholecystectomy. Surgical timing is usually early or interval/delayed. So early is within a few days within the same admission, but delayed, patients come back later on, wait for the everything to settle. Fit for surgery, go for surgery. If it's not fit for surgery, call interventional radiologist, percutaneous cholecystostomy tube, and usually these patients will end up in the ITU. So they will stay with the cholecystostomy tube, and then afterwards, it's a bridge to surgery. It's not kind of like the treatment. But if the patient's really, really sick, then of course we continue managing conservatively without doing surgery with the percutaneous cholecystostomy. So post-operatively, now the patient's got deranged LFTs. What are you going to do? So first of all, tell me what do you think's happened?
Retained stones, retained gallstones.
Okay, stones.
Heterogenic ascending
Organic
cholangitis.
injury, right?
Ascending cholangitis might be due to retained common bile duct stone.
Right, so well, that's kind of like a retained stone progressing to the ascending cholangitis as well. So the next question is, what are you going to do? What's next?
I'd like to do ultrasound first.
The next step is the ultrasound. So the first line imaging is ultrasound, but if the examiner asks, okay, choose one. If we're going to choose one, we're going to choose
ERCP.
of course, ERCP, because it's diagnostic as well as therapeutic as well. So retained stone, iatrogenic, all the biloma formation structures, sphincter folding, again, it's not very, well, it could be spasms and stuff. So start with the ultrasound, and then later on escalate to the MRCP, especially if you don't want to go with the invasive option. ERCP is the ultimate one. So if the examiner asks you what's your first line, ultrasound. What's the only one? ERCP, that because that's diagnostic as well as therapeutic as well. So by the way, why let's say one of the sometimes the examiner could ask you, ischemic hepatitis. Why is ischemia of the liver rare?
The liver has a dual blood supply, one from the portal vein and also from the hepatic arteries.
Very good. So the liver has got dual blood supply, as we all know, right? Portal vein provides 50% of the oxygen requirement, and 50% of the oxygen requirement usually comes from the hepatic artery. Although hepatic artery volume-wise, only 25% of the volume comes from the hepatic artery, 75% of the volume comes from the portal vein. Right, so that is pretty much everything here. So do you have any questions?
I just have one question, sorry.
Please.
Yeah, in case a patient has, let's say, an acute cholecystitis, and I want to palpate the gallbladder, how do I proceed? Like, if the patient is in pain, then would that be a signal? Because that's
so not only in this station, but for all the stations. Let's say you're in doubt whether you should do it or not, whether you can do it or not, rather. So what do you do?
I think we can do at the last of palpation. At the last step of palpation, we can do it. If he's severe pain, we can skip it.
So you ask the patient. That is the short answer to you, especially for the purpose of the exam. If the patient tells you yes, it's okay, doctor, then you can do it. In short, if the patient's got capacity and if the patient gives you the consent, you can do whatever you want. All right, but if the patient withdraws the consent, not necessarily verbally, but it could be behaviorally or any other form of consent withdrawal, then you cannot do it, including, oh, doctor, that's very painful. That hints you that there is a withdrawal of the consent as well. So in short, if you are in doubt, ask the patient, can I have a quick feel of it? I'm going to press a little bit deeper. If the patient says, no, doctor, I don't think I'll be able to bear it, then that's it. Then verbalize it and then move on. All right. Any other questions?
Yeah, so when you're exposing the patient, do you expose before doing the general exam, or you wait until after the general exam before getting the patient to expose himself for the abdominal examination?
If you were the patient, what would you prefer?
I would prefer you to wait until the abdominal exam, but I see conflicting things, so I don't know for sure.
Doesn't matter. What you prefer is what should be done usually. So you should not overexpose the patient. There is no point exposing everything from the general examination. However, there are a few things. For example, if the patient has got a bit of restrictive clothing where you cannot do the general examination altogether, then it's better to expose everything from the beginning. But as long as the adequately exposed for the general examination, then you should do general examination first. For the purpose of the exam, depends on what the patient's wearing. Sometimes the patient's wearing a hospital gown. Then you can just ask the patient to take off the hospital gown. If there is the patient's not, you can't really see everything. For example, ultimately you have to check the chest, etc. For the male patients, they don't really bring in the female patients anymore. For female actors anymore. So most of the time it's a male, and the exposure is quite straightforward. So they are not wearing any shirt, they just wear a hospital gown and usually a pair of trousers. So you just ask the actor to take out the hospital gown. So ideally, the answer is no. You should not expose everything while you're doing the general examination. You should only expose when it comes to the actual examination. But it all comes down to a lot of logistical factors as well. Right. Thank you very much for joining. So hopefully we'll do another mock next week. For those who are taking the exam soon, I wish you all the best. So have a good rest of the weekend. Thank you. Bye-bye. See you later.